Right, good afternoon. Good afternoon, hello. So, welcome to the session called Cracking the Calcium in Modern PCI. My name is Hani Abdelhadi. It's a pleasure to be here today. And it's a pleasure to be surrounded by such good friends and colleagues. To my right, we have Khalid Al-Mirri from Kuwait. To my left, Dr. Fadi Sawaya from Lebanon. And of course, Dr. Sundus from Riyadh. One of our all very senior, very eminent cardiologists. And it's a pleasure to be here today. So I'm just going to start off with a couple of introductory slides. And then we're going to start working towards the session. I have very few conflicts of interest, but I'm always open. So, if we're ready, intravascular imaging, there's a wealth of evidence, a wealth of data showing that intravascular imaging improves both procedural and clinical outcomes in severely calcified disease and indeed in complex disease. You are more likely to use advanced lesion preparation. You are more likely to choose the right stent size. You are more likely to do further optimization post-stenting and to recognize and deal with complications once you image. Now, all of this leads to a bigger stent. Bigger is better. So larger minimal stent area means lower target vessel failure. The ability to recognize complications means lower MACE. So overall, imaging, this has been proven time and time again, improves outcomes. So today's session, we've got eminent speakers who are going to show us case examples of how imaging improves outcomes in their cases. The main concept today is actionable imaging. So we're going to talk about the concept of actionable imaging. We're not going to do an IVUS for the sake of doing an IVUS or to prove that we've done one. We're going to take an image, understand the image, digest the image, and use that to make the right decision. So we're going to recognize and accurately characterize the calcium. We're going to determine the indications for more advanced lesion preparations, and we're going to choose the correct or the most appropriate method to prepare our lesions and to obtain optimal outcomes. And with that, I'll start my first talk. Right, so I'm going to present a fairly basic case today. Here are my conflicts of interest. This is an 88-year-old man, and the first thing we say is 88 years old, he's had a good life, but actually this man is very fit. He's very active, he has an excellent exercise tolerance, walks every day to the mosque, and is a very happy overall gentleman. He's got hypertension, dyslipidemia, and controlled diabetes, and he presented to our institution with an acute non-ST elevation MI. He's got evolving deep anterolateral T-wave changes, his troponin is elevated, but his LV function is preserved. And this is the coronary angiogram. So we have a dominant right coronary artery with no significant disease. We have a circumflex, again, with no major disease, just minor atheroma. And here we have our culprit, very tight LAD, very tight diagonal, angiographically probably calcific in the LAD. So our approach here was to wire both and treat both. So I wired both, and I thought, let me get the diagonal out of the way. And as I dilated the diagonal, my initial concept of using a drug-coated balloon had to fly away just because there's an almighty dissection that wouldn't really yield, so we had to stent it. So we do our IVUS guided stenting. Once I did the IVUS of the diagonal, I found that the ostium is fairly healthy. I don't really need to make this a two-stent strategy. I can land in the proximal diagonal and leave the ostium alone so we don't make this overcomplicated. So we sized our stent and optimized with a very good outcome. That was fairly easy. But now comes the LAD. Now, IVUS wouldn't cross, right? This is an XP guide. Lots of forward pressure. You can see my guide backing off in this view, and the IVUS wouldn't cross. So I thought, let me try a semi-compliant balloon. Now you'll notice I can barely pass a 2.5 semi-compliant balloon. You'll notice that it's not inflating and it wouldn't dilate. And you'll also notice I'm using a guidezilla halfway down the LAD just to try and give myself the power to cross it. So this is clearly balloon non-dilatable. It was also IVL non-crossable. But after this dilatation, I was able to just shove the IVUS a little bit further. Do I always need to? It'd be better if I did, right? So this is what the IVUS showed in that particular region as we did our pullback. So what do we see? We see circumferential calcium 360 degrees, so a napkin ring of calcium. It's dense. There's a large acoustic shadow behind the calcium. It is superficial, and it's a small lumen. Now these together for me equal atherectomy. Whether you want to go rota or orbitals, up to you. I personally use rotational atherectomy, but for me, there was a decision for atherectomy. Now, not all concentric calcium is treated the same way. So this is a different case where I can see that there is thick circumferential calcium, but the lumen is fairly large. There may or may not be a small cushion of fibrotic tissue just proximal to that. So in this case, I'm fairly happy to use balloon-derived therapy, and this is what it looks like after IVL and a non-compliant balloon. You can see clear evidence of vessel preparation and fracture, and we were able to stent this successfully. This is a different case with circumferential calcium, but in this case, it doesn't really seem that thick. Although you can never directly measure thickness with IVUS, you can guesstimate. If you see reverberations, if the acoustic shadow is weak, you can almost guess that it will yield with a straightforward non-compliant balloon, and that's exactly what happened. So we go back to our case. So here we took the decision to rotablate. We took a 1.5 millimeter burr and started off with our rotablation. I already opened my my shockwave balloon, so I've already paid for it, so I might as well use it. And here we like to use stent boost to target our emitters. So remember, the emitters are not exactly in the middle of the balloon, and that's where the majority of the power comes from. So what you want to do is move your emitters back and forth. You can use stent boost to see exactly where the calcium is, and then you can move your balloon just so you can give the energy right at the point of calcium, just so you get more bang for your buck. And we then follow it with a non-compliant balloon, and of course we re-image. So this is what the IVUS looks like after the lesion preparation. Now clearly something's changed. So what we see here is we see multiple fractures, of course, we see reverberations in the red. There's also a bit of a shadow here. There was a small hematoma on pullback. But the vessel is now very well prepared, and we are happy to proceed with stenting. It's always worth looking at your longitudinal view. Here you can see that we've gained a decent amount of luminal gain within the lumen. And I think this vessel was fairly ready to stent. So how do we stent? Well, we go through our algorithm and we look for our landing zones. So we do our IVUS pullback, we identify a decent distal landing zone with a low plaque burden and a reasonable lumen size. We mark it on Cine. We go back until we find a good proximal landing zone using our pullback. We mark that on Cine. So we've sized our diameters. We can measure the length between the two bookmarks. In this case, it was 52 millimeters. And in this case, I was going to use a 2-stent strategy. So we've sized our distal up to 3.0. So we took a 3.0 28 stent. We sized our proximal about 4.5. So we took a 3.5 initially, then post-dilated with 4 and a pot with a 4.5, and then re-imaged. What we look for here is we're looking at distal expansion compared to our landing zones, 100%. Proximal expansion compared to our proximal reference, about 91%. There are no edge dissections and there's no evidence of stent deformation. As we go back and reassess our diagonal branch, you can see here as we do a pullback, there's wide communication between the LAD and diagonal. And we're quite happy that we do not need to recross and we do not need to kiss in this scenario. And this is our final angiographic result. So this was a fairly basic, fairly routine utilization of how the imaging helps us decide on what strategy and how we go ahead and aspire to an optimal result. I won't have any conclusion slides right now because we're going to do that at the end of the session. And I will now invite my dear friend and colleague, Dr. Khalid Al-Mirri, to present his talk.
Good afternoon, everybody. So what I'm going to talk about is the calcified in-stent restenosis. So this is a 70-year-old gentleman who has diabetes, hypertension, and dyslipidemia. He had PCI to the LAD, to the proximal LAD, and mid-LAD with drug-eluting stent in 2004. And he presented with chest pain and shortness of breath. So echocardiography showed severe aortic stenosis. And when we do choreangiography, I'll show you in a second, he has a severe circumflex artery and severe in-stent restenosis in the mid-LAD. And patient was offered CABG and valve replacement, and he rejected that. So we did TAVI first because of the AS was so critical. And we might use like debulking to the LAD. So we thought the valve first would be the best choice and safest choice. So if you look to his choreangiography before the TAVI, you can see there is severe circumflex artery disease, moderate ostial LAD disease evaluated by imaging. It's not severe. And I want to concentrate in the mid-LAD lesion, which is the stent that has a haziness in it extending beyond it. The RC has moderate disease. So we did the TAVI and we brought him back to deal with the LAD disease. So I believe any in-stent restenosis should be evaluated by imaging to understand the mechanism of a restenosis and to guide your treatment. So this is the IVUS. This is distal to the region. I want to this is distal to the stent. You can see there is calcification. I'll stop it and just go with this slowly. So this is beyond the stent, and as we come closer to the stent, you can see there is calcified plaque extending into the stent. So now we are in the stent. If you can see the struts behind the calcium, so there is a plaque, severe stenosis, calcified lesion, and at some areas, the calcium obscure the stent struts. If you look here, you can see the stent struts there, and as you go proximal, you can see there is a plaque with calcified areas, like most probably this is a neoatherosclerotic lesion with calcification, and as we come proximal, you can see the stent, the proximal part is fine. So what we are having here is those are the areas that we have seen in the stent. You can see here is the struts. You can see clearly the plaque with calcium, and this is proximal to it. So this is actually inside the stent, and because of the calcium concentric, there is you cannot see the struts of the stent. So now we know that there is calcified plaque, which stenting those lesions are really not recommended unless you do something to the plaque here. So this is to show you the new rota wire. It is called rota drive wire. This is without a microcatheter. It's like floppy wire that you can really just wire the LAD. You can see it on both sides without microcatheter guide assistance. Then I used a rota ablation, 1.25. The plan was to use 1.5, but it was not available at that time. So the two options were 1.25 or 1.75 for me. So I used the rota ablation, followed by cutting balloon, 2.5. Because I know that we have to do something more than only rota ablation. And this is the IVUS after we did plaque modification. And again, I'll just hold it that way. This is distal to the lesion. And as we come to the lesion, you will appreciate the amount of calcification is less, the lumen is more, and there is calcium fracture. If you look at 7, you can see there is a fracture of calcium. You can see the lumen is bigger. You can see there the plaque has been modified, and there is like fracture of the calcium there. And here also you can see the calcium has been fractured. So at this point, I thought I have modified the lesion properly. You can see here the calcium fracture here and there, and the lumen was bigger with the rota ablation and balloons. So I did a angiography after that. The LAD was really very hazy. So despite I believe drug-coated balloon should be our first option for 2 reasons. It's an in-stent restenosis, small vessel with calcium inside it, but angiographically the result was not really good. So I had to put a stent to cover the whole thing with 2.5 by 32 stent post-dilated. And now this is the IVUS after stenting it. You can see the stent is well opposed, almost fully expanded. We could go more here, but I used 2.75 NC balloon, and you can see now we have good lumen with the calcium behind it. So if we look to the options when you have in-stent restenosis, so this is neoatherosclerosis with calcification. Your options are cutting balloons, scoring balloons, maybe rota ablation when you have lots of calcium. Laser, I don't usually do laser, although it's been recommended. And try to avoid stenting as much as you can. In our case, I couldn't avoid putting a stent. So take-home message, understand the mechanism of the ISR is very important. Imaging is almost mandatory. plaque modification is guided by what you find, and another stent should be avoided if you have 2 layers of stent, if you have calcification, or if you have a stented bifurcation. Thank you very much.
Very nice case, Khaled. We're gonna just raise a few questions. So I think this is very important. You don't really see a lot of usually calcified neoatherosclerosis, and this will change the way you manage. If you did not do an IVUS, you would have not be able to identify if it was calcium or just the struts. So I think this is also very important to why we do IVUS inside of ISR. Any reason you used rotablation versus intravascular lithotripsy, or you think it's not as adequate for in-stent restenosis?
Yeah, when we have calcification and in-stent restenosis, either we have calcium behind the stent or inside the stent. So IVL will be good for the calcium behind the stent, but if it is inside, it will not go anywhere. So you can crack it, but it will stay there. So I decided to use rotablation to debulk the plaque. So that's why I chose it.
I think it's nice to have this discussion after both of our presentations, Khaled, because you can see de novo rotablation and an in-stent rotablation, right? So when you rotablate inside a stent, practically, are you more concerned that if you're rotablating in an unstented segment, is there anything that you have to think about, or any ways you do things differently?
In a stented segment?
Yes, in this segment here that you rotablate.
Yes, it's basically if it's a fresh stent, you want to avoid that, because when you rotablate, you can ablate the stent itself, and you can get entangled. If you have underexpanded stent and the patient comes with in-stent restenosis and you want to do rotablation, you have to think of the risk of burr entrapment. This is a major risk. Otherwise, I think we still can do rotablation to the in-stent restenosis. Just be aware of that risk.
So you think it was safer because the original stent was more expanded and you weren't actually ablating the actual stent itself?
For sure, because the stent was fully expanded.
So amazing case, Dr. Marri. So just like a recap on your case, like first of all, amazing care and action, but you have to understand the reason it happened from the first place. It was the failure to prepare the original lesion whenever the stent was implanted. I think possibly there was no imaging at the first time the stent was implanted, because if they knew what you know, they would have added more lesion preparation, because it is because my talk following you will be about calcium nodule. And if you have a previous calcium nodule and you didn't prepare it well and put a stent, the calcium might protrude through your struts and come, and then it's your luck what kind of calcium nodule you have, a disruptive, non-disruptive. Luckily, you managed it very elegantly and nicely, and you had ended up with good results. But having multiple images is excellent. That help you basically.
But I think the first stent is fully expanded. This is neoatherosclerosis.
And with the calcium
with
protrusion.
a calcium built inside it, yes.
It could be, yeah.
What I liked about your case as well is when you do the IVUS, this is a native, you decided based on the IVUS which kind of therapy you're going to do. So for a very small lumen, rotablation will do a good job. I see people sometimes seeing concentric calcium lumen of 4 or 5 and wanting to use rotablation. And this is not, you're not going to get any gain. But when you don't have a balloon crossing, or even the IVUS is not crossing, this is optimal for rotational atherectomy. So do you have an algorithm in head, or Khaled or Hani, about how, when you choose based on IVUS, certain therapy versus the other?
Yeah. So it depends on what you find causing the in-stent restenosis. So if you have underexpanded stent, mechanical reason, you have to correct that by ballooning. And sometimes laser can work if it is fibrous tissue behind it. But sometimes when you have fully expanded stent and you have tissue inside, now you have to deal with the tissue inside. If it is calcium, you have to shave it. The other thing is when you have neointimal hyperplasia, sometimes we use laser for that. So you remove that tissue, because when you do ballooning, it just becomes behind the new stent. Cutting balloons in those cases without calcification, I think they work. and then drug-coated balloon.
So,
William.
yeah.
Oh, thank you very much. Thank you, Alet. Impressive images showing the knee atherosclerosis that grows inside the stent. This reminds me a randomized trial by Taniwaki in Japan and Lawrence Raber. They randomized patients post-MI with different stents and imaging to look at neoatherosclerosis, just like you've shown. And funny enough, there was absolutely no relation with the procedure. What they found in a post-hoc analysis is that what determined the presence of neoatherosclerosis was the lipids. The lipids. So it had to do with the biology, not with our devices. And so this would be a case, according to that study, that deserves very aggressive lipid-lowering therapy.
It's been thought that neoatherosclerosis is more common with bare metal stents than drug-eluting stent. At one point, that was the theory. Is usually it happens very late and with bare metal stents. And I agree with you. So it's risk factors modification is very important.
So Khaled, we have, why don't you come join us here? We have two side-by-side rota cases, yours and mine, right? And you can see in mine, the lumen was very tight and it was very dense calcium. Yours, it was very dense calcium as well. But there's a big difference in the size of the lumens between the two. And one might argue that the size of the lumen to a 125 burr wasn't that great, but you did do a lot of modifications. So do you think that the wire bias played a role in how you've actually managed to modify this lesion?
I think maybe the wire bias, but it is small stent. So I used 1.25. Hopefully it was the wire that just was biased to one side. But regarding the size, when we have an in-stent restenosis and we have to use a laser, this is one thing that we have to see is how much lumen that we have. We have 0.5, we have 1.4 lasers, we have 2.0 laser. And usually I use the biggest laser that we have, so you want to have to be in contact with the tissue. And if you want to use that, you have to use a bigger guide, but that will get you a better result. With rotablation, I think it is the same thing, how much lumen that you have.
Yeah, because I mean, you can argue it's a 125 burr and the lumen was a bit larger, but you still, like you can see, you've modified it very well. And you'd assume it goes on the outside and it does some kind of modification. And I'm assuming you said there was no 1.5 burr at the time, so you didn't want to go 1.75.
That was my choice. I didn't want to go with 1.75, that's too big.
Do you get a feel when you're rotablating these cases, do you get a feel of how much you're actually doing by how difficult it is to pass? If it just goes through really quickly, you sort of didn't get it, you wouldn't have done much.
I had burrs, they don't want to cross the stent. And once you have really hitting that hard, now you get really nervous. Should I continue to do that? And the chance of burr stacking is high. So yes, I think how smooth it's going, it's very important. When you have really difficulty hitting that stent and it's not going, be ready for stent burr entrapment.
Fantastic, yes, Dr. Khaled.
We have just one question from the audience. Sundus, what do you think of using cutting scoring balloon rather than rotablation?
So it's going to be answered in my presentation.
Go ahead.
We go
There
for
we
it?
go.
Or you want to go for this case or further questions?
Yeah, let's go to your
Oh,
case.
your
This
case.
way you can give us an answer.
Good afternoon, everyone. And thank you for having me. For those who know me, usually they are used to me being on the podium talking about structural cases, but I do coronary cases, and I do complex cases, and I do calcified cases. I just don't do CTO. That's the only thing. So I have nothing to disclose. So the task was given to me is basically calcium nodule, which is not like a mass of hard calcium. It's actually a convex going into the lumen and underlying severe calcified plate. And usually cases which comes with calcium nodule, they increase a long-term major adverse event in compare to patient with lesser calcium nodule. So it's not a very benign thing to take in consideration. There is schematic, like how does it happen? Conventionally, it happens in a hinge point, or there's like a stress and shear of point where you have a capillary burst and then some lipid base, which has been mentioned already. Then it can progress to calcified base and healed fibrotic cap. Why is it important? Because you have to understand what are you dealing with. Are you dealing just with a simple protrusion of calcium? We can see all the edges, or non-eruptive calcium nodule, and that's make it more difficult to manage. So my case is not as elegant as the previous cases, and it's like, you know, representing cases that we see in the cath lab with 6 cases lining up, and someone is screaming outside with a STEMI at the door. So this is the real case that I had with me. So 65 years old gentleman who had a CABG, who unfortunately lost all his graft, and he had an extensive stenting everywhere in a dominant left system. My focus of interest is basically the distal left main with its all calcification. You can see here, it's hazy, it's narrow, it's calcified, extensive stenting at a bifurcation. Spoiler alert, we ended up with 2-stent strategy for this left main. And you can see also, because initially I was thinking I'm gonna go the ISR, long stent, not done by me, okay? But it has a significant ISR again. So, I am a modern lady in a 2025. I'm gonna go with a modern PCI approach. I'm gonna assess, I'm gonna visualize, and then I'm gonna treat, visualize again, and then I have my final decision. So I started, first of all, by dilating the area, because again, I had the same possible problem by introducing the IVUS. Still hazy, doesn't look nice. Let's have an IVUS, let's see what's going on there. And with my target, I want to see the lesion length, the morphology, and the sizing 3-in-1. So in the first calcium, you can see here, like there is like some calcium at the distal here, and some nodules going here. And if you look at the longitudinal, you have a compressional zone there. So we did the IVUS run. Okay, I have all kind of pathologies that you can imagine, because there was a proximal LED stent, there is a calcium cap, a calcium nodule, fibrous cap, extensive calcification, extensive new atheromas. So what should I do now? I did a balloon angioplasty, reassess again. I had some expansion. I didn't like it. I went for a cut-in balloon since I had some fibrous cap to go with it. And then I did again another imaging to confirm, did I crack a calcium? Did I have a lumen gain? So what we can see now, we gained some, there is some fractures. Unfortunately, I don't have Dr. Hani's marvelous arrows, but we gained some luminal gain. We had a calcium crack, as it can be seen here. Okay, we can see whatever was going on here is improved, and we can see some luminal gain. So I did a further modification. I used this time IVL, and I did a 2-stent strategy. In this case, we ended up with LAD, and you can see it is much, much better. And we regained some blood in the distal runoff of the LAD, which is another session which improved. And finally, we gained some expansion. Some calcification has been here, but we modified it furthermore. But after this, we did it. And we did what we wanted to do with this case. So this is what you look, because the question was given that asked me, how do you modify? Look at these criteria. Where is your calcium? How much of nodules is there? The length, the arc, okay? And what is your luminal diameter to improve it? So there is a major rule. There's lots of algorithm going right and left here. So intravascular imaging is the crucial, is the cornerstone. What do you want to do? Have to understand. This is a unique thing that you're dealing with. This is not something simple that you just like take it. We are in 2025, well, end of 2025. So look at it. Look at the nodule, look at the EAL, look at the diameter, the distal, and compare all of this. You will not know this just by 2 images or 6 images, and geographically speaking. You will know it by going in depth. This is what they were discussing just a while ago, because I have like an insight in the future, the wire bias, what kind of rota should you be using. So you have to understand, how can you know the distribution of your calcium if you don't have an image inside of it to decide what kind of burr you're going to use if you're taking a rotablator or orbital atherectomy. So you have to understand the anatomy and the morphology, because no one wants that during his case. No one wants that. So you compare the effects even of atherectomy and intravascular, which is touch-based simply. If you take two cases here, you look at the baseline, okay, it's not only there is a tight lesion, a calcium, it's the morphology, the distribution, the effect, the depth, and then you decide what is the appropriate treatment. In this case, as Dr. Murray mentioned, maybe in post-IVL were good. They cracked the calcium everywhere, and they had a full expansion. Whereas in this case, though they use an orbital atherectomy, there were some deformities. So it's not only expansion of the stent. You might have an area of 12, but look at the morphology and the circle and circumference of your stent. Another systemic approach for calcium modification is like, looking at the subway metro mark. And these are all the calcium modification. Scoring balloon, for those who ask about it, this is the mechanism and this is the specification. How do you know? Again, by looking into the lesion. I will not know this by 2-3 images. High OPN, cutting balloon, rotablator, everything has a mechanism. But in order for you to apply that mechanism in the treatment, understand your morphology. Orbital atherectomy, IVL, and Dr. Kazet has just presented the data about that. So I'm now going to the old days, oldie but goodie. OPN is not bad, cutting balloon has been doing great, so I'll be using it. IVL, yes, I have used it in the case, but I'll be selective in my cases. So you have to confirm the adequate calcium modification has been done. You have to have a specific approach that apply for each patient. And then you confirm eruption of the calcium node, deform of non-eruptive calcium, non-deform, to decide should I go furthermore or should I not go furthermore. And there is multiple, this is like, when you go for the therapeutic approach, and this is what I did in my case. I saw there was some fibrous calf. Yes, there was eruption. We went with high pressure balloon, okay? We did 2 runs of IVUS. I didn't get the partial expansion, the full expansion. I got the partial expansion. So I did a dual preparation using some cutting balloon and IVL, and then I did another IVUS and confirmed what I want, luminal expansion, full cracking of the calcium. Therefore, I went with this, with drug-eluting stent. And then the final imaging to confirm everything is good. With that, I conclude my talk. Thank you, everyone.
Great modern presentation. A very nice case. What are you looking when you're using the scoring balloon or the cutting balloon like the Wolverine? What are you looking and imaging to know that you had a good, modification?
So regarding the cutting balloon, I have been using it more than scoring, to be honest with you, because cutting is more of a non-complying setting, and it has the tendency to malignancy to some extent. So I have to confirm that my position is right, because I don't want a dissection. So this is where, for what the question was just asked, I will go for it. The scoring is more the semi-compliant, so it will be easier. For example, if I cannot deliver the balloon, I can use a scoring balloon. When I look at the image after I do this, I want to make sure there is a breakage or fracturing. If there is a fibrous scrap that already I have some crack in the fibrous or the calcium, plus minus, and then luminal gain. You have to get some luminal gain because you have to prove that your therapy reached or did something. Because even if you have a fracture but still no luminal gain, you cannot put a stent. You have to be very careful before putting a stent. That's why in that slide, we're talking about possibility of DCP. Sometimes you can get what you get. So DCP may be, after IVUS guided, maybe a safe bailout way.
So here's a question for you. If you'd like to join us here, we can
Yes.
have a discussion here. It'll be more I think the bane of our life is this protruding nodule, right? I mean, right now, I don't think any of us can ultimately say that we're comfortable treating nodules. And when faced with a protruding nodule, not an eruptive nodule, but a protruding nodule, you don't know how far it goes. It's the tip of an iceberg. We don't know what we're dealing with. What is the approach in your cath lab right now, real life PCI? You do an IVUS, you see this protruding nodule, and then what do you avoid rather than what do you do? What do you do and what do you avoid in your practice?
So there's a toolbox for lesion modification. If I want to avoid complications, number one. Complications,
Okay.
in general, whatever is the complications,
Yeah.
number one. Number two, I would like to go with the easiest approach before going and jumping with rotablation, for example. But there is something called rota regret, which I have encountered before. So it's like, a gray zone that I want to avoid and at the same time don't want to regret avoiding it.
Okay, so
But
Fadi,
this is real life. I don't want to open the rotablator, first one.
yeah, so Fadi, let me throw you this scenario. You do an IVUS, it's a tight lumen, and there's a big protruding lump of calcium coming into the lumen, right? And you want to treat it. Are you going to go with a high balloon-based therapy? You're going to go with an NC balloon or an OPN balloon? You're going to go high pressure? You're going to go hard or go home? That's the concern, right? And if not, why not?
Yeah, I mean, you don't want to go too hard because you don't want to perforate. So my strategy for these are usually I'll do rotablation first, document cracking, then I'll go with an NC balloon and see what I have. But for these nodules that are, protruding inside the lumen, I like to modify them with the rotablation. That's my technique.
You do atherectomy. Do you do orbital? I don't do orbital yet, but do you do what? You clearly do both. Which one would you prefer to take, or when?
Usually my first choice with a nodule is orbital atherectomy because it makes sense.
Yeah.
It just shaves that nodule, provided that you have like a circumferential calcium. So if it's only a nodule on the other side is not calcified soft, it may not do the job. But my first option is orbital because it shaves in an orbit. Regarding the rota regret, we have data that if you use upfront rotablation, it saves money, less radiation, less contrast, and safer. So we always tend to resist starting with the rotablation because, you will get the machine, it takes longer. But when you look to the study, even it's shorter time if you do upfront rotablation. And the last thing is the Dr. Qusay data on the cutting and the IVL. I'm not sure it's applied to a nodule. We don't know. So the study did not differentiate between those. So I believe a nodule, we should do a plaque, not modification.
Atherectomy.
Yes.
Because think of it mechanically. There's a big lump of calcium right here, and there's a soft lumen right here. You go high pressure, what's going to happen? The calcium's not going to go anywhere. The lumen's going to go this way, and you tear it, right? So you tear the lumen, now you're stuck. You have to stent it. And if the calcium's there, you have an underexpanded stent that looks like a moon, then you may be in a bit of trouble, and you lose the way of coming back with a drug-coated balloon. So if, for example, you use something like either atherectomy, if it's close enough to the lumen, if it's far from your lumen, it's you and your luck with your wire bias. Maybe that's where the orbital can do a little of this. Whereas with the rota, if you're lucky enough and the wire goes towards it, then you might do it. But the other option would be IVL, sometimes, maybe, I don't know, but at least it's low pressure. There's no vascular injury. Worst case scenario, where you started off, you don't have a dissection and you have to bail out and stent inappropriately, right? But it's still the bane of everyone's life, orbital. Do we have any comments?
Drug-coated balloon, are they as effective if you have circumferential calcium? It will deliver the drug to the vessel, I don't know.
It has to be cracked.
Yeah, and when we crack the calcium, we
cracked,
want to see a big crack that preferably goes into the media, so that's the best modification.
We have one question from the audience. Khaled, you can answer this. Any concern of using cutting scoring balloon in left main LAD while you have wire in the circumflex? And the same question for RA or orbital atherectomy. So having two wires, left main LAD, and you're doing plaque modification. And
so with orbital or rotablation, we take the wire out. Some people, they have used the bigger guides like 8 French, put a microcatheter in the circ if they're afraid to lose it. But, ideally, you should take the wire out, do rotablation. Regarding cutting balloon, I know that it's not recommended by, recommendation, but we do it all the time. I never had a wire damage because of cutting balloon.
Same, I do the same strategy. Hani?
So just going to go over the last slide just to try and summarize. So we've only got a few minutes left. If I can have my slides up. Okay, so I think we need to leave with a theme, right? And I think the theme is consistency. Right? I love this quote, Warren Buffett. Everybody wants to be Warren Buffett, right? But you keep doing the same thing, you'll keep getting the same result. And you have to have a system. And the systems are actually universal. You know, if you do the same thing every time, you're more likely to get a positive result most of the time, if not every time. So the concept with image-guided intervention is the concept of actionable imaging. You see an image that will help you decide on the right action, and then you take it from there. So pre-PCI, you plan your procedure. Is there calcium? Where's the calcium? How do I prepare it? You know this from your first run. Once you've prepared your lesion, you have to re-image. You have to make sure that you've modified the lesion properly before you put a stent in there and then regret it afterwards. And of course, post-stenting is very important that you optimize. Quite often, and you see this in all the trials, you still need to optimize even after very good lesion preparation, and you end up going more and more non-compliant balloons. You end up with a bigger stent area. Now, regardless of what method you use, so this is IVUS 1, 2, 3, we see this, we all hear about MLD max. It is exactly the same thing, right? It is exactly the same system. Whatever you're doing, you're assessing before, you're assessing after preparation, and you're assessing after. And that's the take-home message for us today. It's about consistency and about having a fixed way that you do things that you always do so you can get a better result. Do we have any questions or any queries or any issues that we want to discuss? We've got 3 whole minutes.
Yeah, I think the message was clear.
Yes.
Prepare the lesion, do imaging, don't be blind, know what you're looking at, understand the workflow, use the right modification if you need to, and then look at your result, make sure you did the right job before going home, because you're really gonna impact, and this is guideline directed. You need to do that to get lower MACE compared to doing it just angiographic based.
And while we've got this for another couple of minutes, let's talk about the new AI in IVUS. I mean, have you got the newer systems in your cath labs? Are you using the Vigo Plus? You've got it in yours?
Yes, we have the Vigo Plus, and I think it makes your life way easier. Of course, a caveat, you need to also not trust blindly, especially with in your session that we saw at the forum with the OCT as well. Like sometimes the boundaries or catching the struts that are malapposed, you can be fooled if you don't look at yourself. But of course, everything is going to be AI driven in a few years, and we're going to be just plugging numbers and reacting accordingly.
I think for me, I don't know, Khaled, what you think. I think regardless of whether you're using IVUS or OCT, AI does for me 2 things. There used to be a big sigh when you tell people in the cath lab, open the IVUS. I was like, oh, come on, it's 8 o'clock, we need to go home, it's late, it's the weekend, my kids are hungry, come on, why you want to open IVUS again? And that's general consensus people tend to have, right? It's going to take up time and you're going to delay us by another half an hour.
Used to be.
It used to be.
It used to be.
It used to be. So I think the AI does 2 things for us. The first thing it does is for an experienced operator, I think it makes you much faster, especially post. Expansion, appositions, and that sort of thing with OCT. But with IVUS expansion, you used to have to go frame by frame to look for it. Now you get an MSA, now you get an automatic expansion. That's very important for you. So it makes an experienced operator much faster, but it also helps bridge the gap between those who are less experienced and those who are experienced. And I think there are going to be some new updates that are going to come soon. They're not going to tell us, but I know that there's going to be co-registration coming soon and a few more updates coming up soon. So, and with that, I think I've got very little else to say.
Yeah, we can conclude. I think this was a great session. I hope we were able to convey the message about imaging and plaque modification and the 1, 2, 3 of IVUS. And thank you.
Actionable imaging and consistency.